So welcome everyone to the SADS Foundation's Living with SADS webinar tonight, where we plan to answer your questions about exercise and sports participation while living with a SADS condition. I'm Marcia Baker, the program director for the SADS Foundation. We are honored tonight to have two medical experts who are volunteering their time to address your questions. You may post your question in the chat box. A reminder to keep it pithy, or you may raise your hand and we'll call on you to unmute yourself and you may ask your question verbally. We've had an overwhelming response with over 250 people for this Q&A webinar. So we have a limited amount of time, only an hour, with Drs. Ackerman and Tandri. So we'll post a link in the chat to frequently asked questions on our website in case we don't get to your question. So now it's my pleasure to introduce our two experts. Dr. Mike Ackerman is a genetic cardiologist and director of Mayo Clinic's Windland Smith Rice Genetic Heart Rhythm Clinic and Windland Smith Rice Sudden Death Genomics Laboratory in Rochester, Minnesota. He also serves as president of the SADS Foundation Board of Directors. Dr. Hari Tandri is a cardiac electrophysiologist, clinician educator, and director of Vanderbilt University Medical Center's Arrhythmia program in Nashville, Tennessee. He's an internationally recognized expert in arrhythmogenic right ventricular cardiomyopathy, or ARVC. So thank you again, Dr. Ackerman and Dr. Tandri, for your time in addressing questions from our communities. Mike, I'll turn this over to you now to make some opening remarks and help in moderating the questions.
Great. Well, thank you, Marcia, and Happy New Year, everyone. Welcome to SADS Foundation, our webinar on SADS conditions and sports. It's just great to get to be with you. You can set your clocks right now to a 3-minute monologue. So I'll give me 3 minutes starting right now. And that's just to share with you the journey that we've been on. I joined Mayo Clinic's faculty in 2000, so 23 years ago. Back then, the law of the land was, if in doubt, kick you out. So when it came to life and sports and a SADS condition, it was largely viewed as oil and water, right? They don't mix, can't do it. No, you can't. Don't ask me again. You're done with whatever you were doing. And at that time, it made zero sense to me. I thought that was the wrong way of doing it. I thought it was the cruel way of doing it. I thought we had to do it better. And raised my hand at a meeting and said, why are we doing it that way? Why don't we do it the way we do so much of all of medicine, which is to share the risks and benefits as best we can with our patients and their families, allow our patients and our families to partner with us in what we call shared decision-making, and recognize that a continuation in sport or a return to sport would not be a zero risk proposition, but on balance, it may be a better proposition than sentencing you to a sedentary lifestyle. All the messaging that some of you grew up hearing, don't get off the couch. If you get off the couch, get up slowly. If you have to go to the bus, walk slowly. And the kind of messaging we did that was very much a don't. Sports are spooky. Sports are dangerous. It's going to sneak up and bite you. And I still agree that our way of doing it at Mayo was the right way in 2000. It took a long time for the rest of the world to catch up with our view and start to embrace it. Now, I'll tell you, the majority of cardiologists are still kick you out kind of cardiologists. But there's a growing and a large enough minority where we're starting to gain traction in the notion that the approach is the right approach, morally, philosophically, and that we now have data from large cohorts of patients like mine and others, where we have shown that we can return you to your sport safely, almost always, some exceptions, we'll talk about those, and that the downside of return to sport, or the upside, is far, far greater than how many of you might have been captured under if you were diagnosed in the 1990s, early 2000s, or depending on your cardiologist, you may still be sentenced under a notion of thou shalt not do that, you can't do that, you won't be doing that, take up crochet or croquet. And so we've come a long, long way. I'm excited to take your questions, but before we do, I want to turn it to Dr. Tandri, because that evolution of thinking has been much slower to arrive in the land of ARVC. If we've been restrict with long QT, CPVT, Brugada, and so forth, starting circa 2000, and just starting to liberate you, that approach to ARVC has been an approach of much more severe restrictions held in place much longer, meaning ARVC families are largely in the penalty box, and many of them still in the penalty box, including the ARVC family I saw just the other day, Ari, as in yesterday, who was told, you have a positive genetic test, I can't see anything wrong with your heart, but you won't be doing any sports, period. So we still have a long ways to go, but maybe Dr. Tandri, could you reflect specifically on your own thinking perhaps, because maybe you started in a posture of being thinking that the best thing to do would be to shut down the ARVC person, and maybe starting to view that there's got to be room to let them do more. Hari, what say you?
Yeah, thanks, Mike. Thanks for the sort of an introduction into connecting the exercise and ARVC piece. Just a brief history of how I got here. I joined Vanderbilt about a year ago. Before that, I was at Hopkins for 23 years in the ARVC program. Following, after I finished my residency, that was my first research project that I took over, was ARVC. Hugh Calkins, who leads the program, called me one day and said, nobody knows anything about this disease. We need to figure this out. And that's how I got in. It was a mouthful for me when I started. I couldn't say ARVC properly. It was like it's like ARVD, AVRD, and all sorts of things. It kind of started there. And slowly worked into diagnostic criteria and so on. But it was striking that the patients who presented initially with the condition were all athletes. And sudden death happened during exercise. Most of them had all their symptoms getting worse during exercise. So we went to that defensive approach of saying, if you had this condition, you play flute and you play golf. That's kind of pretty much it. So it's almost like going to a defensive position to see, let's figure this out before we open the doors. It has taken a long time to open the door. And it's still doors kind of partially closed, I would say. But our understanding of this condition has improved a lot over the last 20 years. We have successfully, taken care of teenagers who have practiced at a very high level in athletic activity. Even with the diagnosis, we've handheld and walked them through. And we understand that this is life. This is, if you don't do anything, if you sit there, that's not living. And really, I think, try to work with people on an individual basis, giving recommendations to see what fits their profile. So it's almost like a personalized approach to taking care of people. But there's still a long way to go on our understanding of how to advise people and what can they do, what can they not do, and how to take the fear out of doing things. You could be doing things, but if you're constantly worried about your heart rate, you're looking at your watch to see what heart rate you're hitting and whatever, it just takes the pleasure out of whatever you do. So I think it's an important area of research, even in ARVC, much slower, as Mike alluded to, with just about getting there. But this has been an interesting journey for us, and yeah, look forward to your questions and hopefully be able to, answer a few of them today.
That's great. Thanks, Dr. Tandri. Well, let's get this party started, everyone. I'll look on the sidebar to the chat group. Rapid fire away. We'll take them in order. We won't cherry pick them and only take the ones that we know the answer to. And we will try to be as tight with our answers as you are with your questions, so that we can get as much in and covered during our next 45 minutes. And if there's a shout out, we could do a shout out too. This is your night.
You can begin posting your questions. Oh, we have two participants that have raised their hand. So let's go to those. Let's see here. We have Kevin McCullough. Go ahead and unmute yourself.
Good evening, doctors. Thanks for doing this. I have a son who he has ARVC. He sustained a cardiac arrest on a basketball court. He does have an ICD. We've been told, obviously, competitive sports, which unfortunately he's very good at, is out. But we've been told low to moderate recreational activities. So what does that mean?
Yeah, Hari,
No,
I'll have you take
ahead,
this.
Bob.
One
Yeah.
of the things I'll say is we will take your question and do our best to make it general to the topic and not to suggest that we're giving you or anyone
Right.
specific advice, since we don't have the privilege of being your physician and reviewing all the data directly. So I love the question. It's a great one to start, but just want to let everybody know that Hari and I won't be giving a patient-specific recommendation per se. Hari, go ahead.
So, so Kevin, it's a fantastic question. I think this is one that most parents go through. You have a kid superstar, trying to, play for college. That's his life. He has his friend circle. This is the whole thing he lives on. And you take that away, it's pretty much you taking the youth away from him. I would say the downside has been pretty much, capped. If you have a defibrillator, right, you're pretty much taking care of the sudden death risk. Now, then there's this risk of progression, or are we going to make this condition worse? Now, there are certain guardrails that you can actually use. You can basically monitor what's happening in the device when you exercise or when you practice. And there is certain, clearly, I would say that, if you're trying to continuously improve on yourself and try to improve your timing or whatever it is, that's one thing that ARVC hearts are not good at, right? The remodeling process is a problem. But if you're just hanging out with your friends, shooting hoops, and you basically are having a good time, we can closely follow these patients to see if it increases their arrhythmias, or it starts to show signs of right ventricular, weakness or whatever, and we can back off. So they do need closer monitoring, but you kind of let them do what they're doing, but with fences and boundaries, just to say that, okay, fine, let's agree that you'll be comfortable doing this. So let's closely watch you to see what happens when you do that. Obviously on one end, if you do this, you go to your basketball court and you get shocked and whatever, that's a whole other thing, because it plays into the mental thing. It just causes mental, PTSD and so on. But other than that, if he's able to carry on stuff and whatever, you could set some saying, is this okay? Just to come up with a, agreement that you could do recreational, you could play sports and whatever. We're going to closely watch you, maybe do a Holter monitor, periodically to see, are we making his arrhythmias worse? And those are the metrics that we actually use to say, this is okay. Whatever you're doing is fine. Let's keep it at that. And if anything changes, we can always come back to the drawing board and see, what we need to do. So there is some give and take here, and the kid has to be there in that whole decision making, make sure that they're comfortable with what they're accepting to.
Yeah, Kevin, I love the question, and I'll just put out a perspective. So every athlete of mine, and I see JC on the call, they know this. If they're with me, they're to ask the two O's. Is that activity O optional in your life, or is that activity O oxygen? And if it's closer to oxygen, we try to keep it in play. If it's optional, why accept any risk? It's not worth it. And after that whole discussion that Dr. Tandri was speaking of, the family unit may say, this is actually closer to optional. I don't think I want to do this. And others will say, no, this is my oxygen. And I'll be a little bit radical for you out there and maybe hope-filled and hopeful. I have many athletes who are sudden cardiac arrest survivors who have their sudden cardiac arrest due to a lesion called ARVC, and they are still elite athletes. at the highest levels, including professional ranks. So nothing is off the table automatically in our program just because somebody sustained sudden cardiac arrest, especially if that sudden cardiac arrest occurred while undiagnosed and therefore untreated. After diagnosis and after treatment, if we're still close to oxygen, we try to figure out non-competitive sports, competitive sports, elite sports. Is NBA still going to be a possibility? Is NHL still going to be a possibility? Yes, it is. And yes, they are playing at the highest league. So I'd never remove it until we all decide together that it's closer to optional, and then we monitor things. We'll go tag team here with, I'll see on the sidebar, and then Marcia, maybe you can take the next hand raise, but I'll grab the sidebar ones and you do the hand raise ones.
Sounds
So
good.
Courtney's asking a question about medications. How do we decide what type of beta blocker to prescribe, or what tier of beta blocker to prescribe a child that's on propranolol? So really, whatever the heart condition is, if Dr. Tandri and I think beta blocker therapy is indicated for almost all of the lesions represented in SADS condition and SADS Foundation, we like propranolol and nadolol the best. We like metoprolol and atenolol the least. And then we target the dosing by a variety of parameters, the Holter, the treadmill, and to get to trying to maximize the dose of the beta blocker based upon our perceived threat, while also trying to not shift it into a new problem called every day of my life beta blocker side effects. So it's a careful balancing act that we try to balance, working with you and the family and the tests and the assessment of the threat at hand. So a hand up one, Marcia.
All right, Patricia Beatty, go ahead and unmute yourself and ask your question.
Hello, can you hear me?
Yes, go ahead.
Okay, so some of my question was answered. My daughter, at 16 in July of 2022 suffered a sudden cardiac arrest. All is well, thank God. I'm medical, so I was kind of prepared and knew exactly what to do. Aside from that, this happened on vacation, walking. She's a competitive dancer. So with her doctor here in Orlando, we've kind of gone round and round, but have landed on, she's on nadolol and flecainide, and the exercise-induced stress tests are normal. My question is kind of twofold. One, the doctor still kind of is pushing the ablation, where I don't think that that's necessary if the medication is working. So I just wanted, not to contradict a doctor, but I just kind of wanted opinion on that. You know, if my thinking is correct, and if the medication is doing its job and we're doing stress tests every 6 months, she's dancing, she's worn Holter monitors and everything seems fine. She's had no episodes. So
The question, I'll have Dr. Tandri tackle this because it's an incredible success story in science and medicine of how CPVT therapy, the treatment of choice, basically is combination drug therapy with nadolol and flecainide. And it turns out that that exact same therapy is emerging as potentially the treatment of choice for ARVC with a positive stress test. And it's a pretty cool story because at the cellular level, some of the desmosomal changes of ARVC start to mimic the calcium mishandling of CPVT. But Hari, you've got a patient where you've chosen nadolol and flecainide. You love the stress test result. What's then your threshold for moving the patient to ablation?
So there has to be some value that you provide with any ablation procedure. I think in this particular case, there is no value. You know, you're not getting anything out of it at the end. If you either have, you hate flecainide, you don't like the side effects of it or whatever, or despite flecainide, you're having breakthrough episodes, that's when you really go for something else. Right now, just based on what you just said, I'm not sure there is much to do in terms of an ablation.
Okay, that's kind of where I was thinking. I have obviously this runs in families, so I have a nephew who's having breakthroughs who had the procedure, so I'm totally on board with that. I just don't feel like my daughter's there when it's working flawlessly, knock on wood. My second question is, she's graduating and wants to continue dancing at the collegiate level. I'm seeing, depending on where she goes to college, the transition to, I know there's a broad theory of, cardiologists and the electrophysiologists on who's on board with this exact topic. Some of them are still very afraid. So is there any recommendation on how to broach that should she want to continue that at a collegiate level?
So it's basically a thing. It's in my sense, it's a big discussion in this time of the in this phase of life when they're going from high school to college and whatnot. And once they go past college, they get into other things. You find a job, other things come up in life, and whatever. This starts to become less and less and less of that big of a problem, and your understanding also improves. I think it's important for us to handhold them through this process and closely watch them in terms of, are they having more activity on their Holter, or they get periodically followed. And if they do participate in anything, make sure that they're well hydrated and they take their medicines regularly and they take their beta blocker and so on. Once you do that, I think it should be okay. But in general, I think there's a lot of data from animal models suggesting that the more you stress your heart, the more likelihood you are going to cause progression of arrhythmia or progression of fibrosis. It's hard to show that in humans, in any meaningful fashion because of the time course that's involved, right? You probably have to follow them years and years and years to actually show that difference, especially them being so young and they have a very long life in front of them. It's almost like you're sowing the seed to make sure that you'll be fine. By the time you get to 50s and 60s, you'll still have all the same energy that everyone else has. So I think it's good to come up with some sort of an arrangement where they would slowly back down a little bit, but at the same time, let them do in a very controlled fashion. Does that make sense?
Yeah, it does. And I liked Dr. Ackerman's, the 2 O's, that kind of hit home for her, because she doesn't want to be a professional dancer, but this is something she's done since she was 5, and had no issues until on vacation. So I understand where it's hard for her to stop, because it is kind of something she lives for, but she doesn't want to do this long term. So that is kind of a discussion we'll have to have. So thank you.
No more vacations. I'm just
Yeah, I think the other thing for our athletes out there is that, as we do shared decision making, that can change once it goes to a TDM or a BDM model. TDM, their decision making, and BDM, business decision making model. And so families need to be prepped that what was working beautifully prior to signing on at the Division I university or the Division II university suddenly got the rug pulled out from under them because the university officials became risk aversive, and they said, we don't care that you're under the care of Ackerman or Tandri, you're not playing here.
That's what I'm concerned about. Yeah.
And that is a very real possibility, because the one thing we won't change is what our requirement is for the emergency action plan, the safety drill. And if the university embraces it and says, yeah, we can do that. We have emergency action plans for our diabetics, for our epileptics, for our peanut allergy athletes. We can add the safety plan for you, then great. If they say, oh, not touching that with a 10-foot pole, then you don't sign. And so I tell all of my athletes, never, ever sign your letter of intent at a college based upon the coach's letter or the until you run it up the university poll, because you need to get the clearance, the green light from the appropriate team physician, medical professional. Maybe we'll continue if there's another question along that line. On the sidebar, there's a shout out to you, Dr. Tandri, when you were at Hopkins, because you turned their world around and gave this hockey player a second chance after getting an ablation. So perfect time and place for ablation. It has to be the right therapy given to the right patient at the right time. And that's the whole role of you being under the care of a true specialist for your disease and not a generalist. And Jay's same question. So since that wasn't a question, I'll go to this one from Heidi. And Heidi is not diagnosed, Hari, with ARVC, but has the positive genetic test. And so are there limitations to exercise in somebody who's in this, what we call genotype positive? Your genetic test is positive, but you are phenotype negative, meaning we can run the whole cardiac test drill on you and your tests look very, very normal. Does that person need to be shut down from everything? If they go for a run, is that going to trigger the disease, Hari?
No, not so. Again, it depends on which age group you belong to, right? So if you're a teenager, I don't know. I don't know if you still are, you are going to show signs of disease by the time. Generally, something happens between the age of 10 and 16 or 17. We don't find it in 10-year-olds and 11-year-olds, but by the time you get to 15, 16, 17, suddenly start to see it. So something switches. But if you pass that age, if you're a 25 or 30-year-old with the mutation and you haven't shown anything, then there is no restriction. You keep doing what you're doing. We closely watch you like we do surveillance. Probably you do an EKG or Holter on an annual basis and keep an eye on it. And as you start to get into your 40s and 50s, probably spread it out 3 years or 5 years. And once you cross your 50s, and if you haven't shown anything, then I think you're good.
And we'll give you some more 2024 good news. I think a lot of families find themselves under this death sentence where one of these years, all of my tests are going to go abnormal, rather than realizing that ownership of the mutation only predicts the chance of the disease showing itself at about a 50-50 chance, meaning you can own the mutation and statistically you may only have about a 50% likelihood of ever showing the disease. That's called penetrance. And so just because you own the genetic test result doesn't mean that this year's evaluation is going to go south on you, or the one in 3 years. It may be normal indefinitely. And that's why it's important to stay connected so that we can monitor closely, so that let's say we did see onset of disease, and now we ask you to scale back on your level of endurance training because we're seeing that you're one of the penetrant ones. And so staying very coupled to your team is really important. Marcia, a hands up person.
Okay, Bruce, you were the next hand I saw. You may unmute yourself. Go ahead.
All right, thank you. Can you hear me okay?
Yes.
Yeah, thank you, everyone. Really appreciate you taking the time to do this. By the way, I was the one that posted about, our 17-year-old playing hockey, and we're so appreciative of that. And I guess the one thing that kind of plagues us to date is that I have the gene, and so does my other son. And exercise, at the time, Dr. Tandri, when we were there, was kind of off limits for us anymore. And now it sounds like that's something that we can look at again. However, do doctors in different areas, what kind of resources can we even help point them to help them understand what to look for and what to monitor? And one concern we have, even with our son who has ARVC, is how much progression would we expect from a certain level of activity? Is there any kind of gauge that you've seen with studies over time?
So Bruce, I think you connected with the Hopkins ARVC program, of course, and so it's a great resource. So what you need to do is probably annual Holters and ECGs. Usually, if you send them, and they're just a phone call away, and I'm just a phone call away. So pretty much, we're all connected to that network. So it should be easy to get help and advice on how to interpret the results and how it's changed from a year-to-year basis and so on. Progression seems to happen very, very gradually. And again, if you present in teenage years with already quite moderate to severe right ventricular failure and so on, it seems like there is the higher chance of progression because you really have a lot of lead time before you need your heart for another 50, 75 years. So I think that really determines how closely we follow them. People who actually present early with lots of structural diseases who we are closely following. But other than that, I think we perform routine echocardiograms probably once a year just to look for right ventricular structure, change in right ventricular function, and so on. And if there's no change on year-to-year basis, no change on your Holter on a year-to-year basis, I think you're doing okay. You're doing good. So, but unless you dramatically change your level of physical activity and so on, that you need to keep us posted, then we'll probably see you on a sooner basis. So whatever happens, happens gradually. And it's rare that we actually see patients who have a clinical diagnosis of ARVC and suddenly start to develop progressive ventricular dysfunction. And we've gotten those wrong. They ended up being sarcoid, something else, some inflammatory cardiomyopathy that we initially thought was ARVC, but ended up being something else. So in general, I think progression is gradual, slow. So we have time to, say, well, we can dial back on this and change the course of it. So I think that gives us some comfort in saying we can let loose a little bit and then go back and, turn around when we need to.
Okay, great. Thank you.
On the sidebar from Teresita, and boy, I love that name. So Teresita with ARVC. Yeah, hi there. So ARVC, Tandri, life-threatening arrhythmia, structural damage, ICD. She walks and lifts light to moderate weights at 3 to 6 METs for about 90 minutes. Is this too long? What are your thoughts? Sounds great to me. I think, so I'll take that one. That's I think what you're doing is fantastic, and we'll do how do you feel weightlifting is for ARVC. I love weightlifting. From honestly, there's not a single SADS condition, not a single one where I restrict weightlifting. Now, I'm not encouraging anybody to do, a deadlift Olympic record with incredible resistance and that type, but weightlifting, yes, risk for the ICD, risk for the heart, risk for a lead, almost zero. So the whole weightlifting thing, let's put the weightlifting category largely as a fake news. Can we do that one for fake news one? Okay, Marcia. And on.
Okay, Andrew, well, hi there. You may unmute yourself.
Is my audio okay?
We hear you? Yes, go ahead.
Wonderful. Let's see. So my history is as a adolescent and child, I was diagnosed with exercise-induced migraines in the context of exercise.
Tight question.
What was that?
Give us a tight question, Andrew.
Brugada syndrome. The person who competed in the triathlon. A triathlon has water involved. I was told to stay out of the water. What's your advice on water activity for Brugada syndrome?
Yeah, so I would say in general, there's zero data, that swimming is pro-arrhythmic in Brugada syndrome. There's minimal data that swimming is pro-arrhythmic for CPVT or long QT, believe it or not, after you've been diagnosed and treated. Now, how have there been a lot of near drownings? They have come about by way of revealing the disease. So you're undiagnosed and therefore untreated. And that's largely LQT1 and CPVT are the two SADS conditions where swimming is a known trigger, but that trigger is almost completely resolved, neutralized after diagnosis and treatment. Now you take precautions, and for some, the triathlon component may be a bridge too far. So in triathlons, people may or may not know this, there's a disproportionate number of deaths that occur during the swimming phase of the triathlon. And that has nothing to do with genetic heart disease. It has things to do with some of the breath holding and the flash pulmonary edema, or just getting knocked unconscious during the swimming phase of the triathlon. And so I'm not a big fan, honestly, of the swimming portion out in open water, just because if that's where an event were to happen, it's a fairly unforgivable setting. Whereas my swimmers who are Olympic level swimmers in a swimming pool, I have no problem with them going back and forth, back and forth, back and forth, because they're in a confined space. The rescue plan is right there. The observer is right there. And so I think it kind of depends on how mission critical is the triathlon for you, the swimming portion versus shifting to the duathlon and things without the swimming portion. Hari, anything you would add?
Not really. I think the most of the the data, again, this is specific to Brugada syndrome. Your question specific to Brugada syndrome and swimming. I don't really think there's any data that is against swimming, especially in the setting of Brugada syndrome. But I agree with Mike. I think if you're not protected with a defibrillator, and you're swimming in a open sea or in an open lake or whatever, that's an unforgiving sort of a circumstance. And it's not infrequent. We actually find out patients with accidental drowning and you rescue them, and that's the first presentation with sudden cardiac arrest. Once you're protected or in a very confined setting, I think that should be fine. In terms of, it would still come under endurance training, especially for ARVC sort of setting. It will still come under endurance training. So I would say it's still, if you're training constantly in swimming, we would still like to closely watch you for change in structural, cardiac structural changes, or in the development of arrhythmias during swimming and so on.
Great. On the sidebar, and Mike, I might need you to unmute yourself because I'm not sure of this, but the question for us, Dr. Tandri, is whether we have anecdotes about our patient athletes who have received creative or particularly interesting accommodations from their school or team. And I'm not sure what that means. So Mike, feel free to unmute yourself. So I personally follow over 800 athletes that I've supported their return to sport. And so far, I've never done a creative accommodation. So I may not know what that exactly means.
Okay.
So go ahead, Mike.
Thanks for taking this. I appreciate it. I'm just, aside from having the plan, aside from having coaches, no CPR and the AED on site, I just want to know if there's any other, just for brainstorming, if there's any other interesting stories you guys have about schools that have gone, or teams that have gone the extra mile to help out their patients.
Yeah, well, maybe, okay, so this is the accommodation that every athlete of mine gets. And I don't know if it's creative, it's brutally straightforward. Every athlete and their team physician and the team must embrace the following emergency action plan, or EAP. And that is, if the athlete collapses and doesn't regain consciousness in 10 seconds, you assume it is the disease causing cardiac arrest, number one. Number two, if they don't open their eyes in 10 seconds, you've assumed cardiac arrest, you've activated 911, you've started chest compressions, and you've grabbed the AED, the external defibrillator, and retrieved it, applied it, and hit the shock button. Now, I still do that drill, and every single one of my athletes, 600 of my athletes, do not have an internal defibrillator. So 600 must have that EAP. And to date, 600 athletes, 20 years, that drill has been activated never. So that is 0 for 600. And yet the school still must embrace that drill, that accommodation. And if they say, nope, we're not going to have an AED, then I say, nope, you're not playing, because I keep the safety plan in place, just like I keep my fire extinguisher in place in my home, even though I still have never pulled the pin in 20 years. So that's, I guess, the universal accommodation that I require for every one of my athletes.
I have generally we say that if the patient passes out, like it's a slightly different situation than Mike and most of the athletes that I deal with have a defibrillator and are still playing. So we just, tell them the cutoffs are too high. So they're not going to hit that cutoff to spontaneously figure the ICD off. But if they pass out on the field or if they get shocked on the field, you should pull them up. They're not allowed to play again. Simple rule. But the athlete should declare that he actually got shocked. You'll be surprised. You'll be surprised that there are kids who get shocked. They know that they just had a VT event, but they don't tell anybody. They keep playing. So that's one of those things that, I think they're protected. They do. It is true that when they're really, having this adrenaline surge, they're competing against the team. They do go into arrhythmias. It is one of the risks, but it is what it is. You just have to carefully watch, and thank God nothing's actually ever happened that, that we haven't had any big problems on the field. But that's one thing that, we tell them that these things could happen, and the families are educated on that, and everybody agrees to saying that these are the risks we're actually taking by let them playing at a very high level, competing with this condition. But I think they're still protected from sudden cardiac death.
Great question, Mike. And Marcia, a hand up one.
Yes, the next hand I see is Jamie Jones. You may unmute. Go ahead, Jamie.
Yeah, so back in August 2022, I had a VT playing basketball and out here in LA, and I went to Sunset, had all the tests done, everything came back normal, even stress tests, and then they put me on metoprolol, and my cardiologist said she wanted me to get a genetics test, and it came back that I had the PKP2 gene. So then they figured that I had, ARVC. Then they started doing Holter monitors, and those came back normal. And I did MRI, and that came back normal. And I just had another MRI this past August in 23, and everything came back normal on that, and even my echoes. So right now I'm kind of like in a box because I even went to UCLA, they referred me to, and still UCLA kind of was puzzled and they didn't have any answers for me. So right now they don't want me doing any weightlifting. They don't want me to do another stress test or anything. And right now I'm just on bisoprolol, Zebeta. And I don't know how to proceed and what I should be doing. Should I be lifting weights? They say I should get a ICD. Some say I don't really need it, or I can just stay on the beta blocker. So I get a lot of confusing answers. So I just don't know where I should proceed. Should I lift weights? Can I do like walking the hills consistently on beta blockers? So, I'm just kind of like in a hard place right now.
Yeah, I love your question, Jamie. I think every family who doesn't feel like they're getting clarity with the roadmap to follow should get a second opinion. Pure and simple.
Yeah, we tried that because I wanted to go to Cleveland Clinic and Johns Hopkins, but they don't do second opinions over, Zoom. So kind of like right now, it's like, what do I do? Because, weightlifting is was like my grounded place. And then now my doctor's out here telling me, don't lift weights. We don't want you going to an arrhythmia. Stay on your Zebeta. And right now, just don't do anything that will, I guess, progress the disease that they still have not even diagnosed me yet. They just say you may or may not have it.
Yeah, there's one of the beauties of the pandemic, if there was something beautiful from the pandemic, was the ability to provide first consultations virtually. When they declared the pandemic over, Dr. Tandri and I are only allowed to do first consultations remotely for those states that we are licensed in as physicians. And then follow-up evaluations can all be done virtually. So it may mean that if you need to leave California, you actually need to physically see somebody, and it may well be worth it. In my program, all I can tell you is I don't restrict weightlifting from anybody. I think zero data. But there is data for those out there in ARVC land, and it's data that our program published first or second, and Chris Samsarian down under published first or second, that PKP2 can present as a mimic of CPVT while the heart looks perfectly normal structurally. And in fact, it led to, for a while, where people were referring to it as PKP2 mediated CPVT. In other words, there's an arrhythmic electrical expression of PKP2 disease that can precede any imaging changes.
Mhm.
And so Hari and I would have to review your mutation, ask ourselves, do we really believe that it's a true disease-caused mutation? If it is, it's not surprising at all that it could be showing electrical changes first
Mhm.
before it's showing any overt structural changes.
Yeah.
Dr. Tandri, anything you'd add to that before I grab one on the side?
Well, yeah, I think when you presented with VT, I probably would assume that it was a stable VT, that you were in VT, and then basically.
Yeah, it was benign. Yeah.
So that itself, that's not uncommon with ARVC too. A lot of people have had years of VT before they actually present.
Mhm.
Later on in ARVC, the most dominant arrhythmia is VT. In teenage years, it's mostly VF. So sudden death happens earlier in the course of the disease. Later on, it just becomes more of a VT sort of a condition. So that's what you have.
Yeah.
And there may be some specific triggers for VT and so on. And some, in Europe, it's not uncommon for them to treat this with just beta blockers and sometimes just with flecainide and see how things go. And
Yeah. So I'm 36 now. So it happened when I was 34.
Yeah.
Yeah, get ready to turn 35. So it happened then. But I'm on bisoprolol, and right now it's been working because I've had a VT since August 2022.
Okay.
So
So
it's been,
again,
yeah.
it's probabilistic. It's not something that, again, even patients who have a lot of ARVC basically have, a probability of having VT. Your probability seems low,
Yeah.
but definitely help for you to get a second opinion. Looking at all your records, looking at your MRI as well.
Yeah.
And MRI interpretation is a big problem on how people look at it. So I think.
Yeah. They said I had a dysynchronous wall motion, and then the radiologist read it and was like, this is not consistent with what we see with ARVC. So they still get confused out here as my cardiologist on what I have. So they want me to do an ICD, but the beta blockers are working right now, and I haven't had a problem in a year and a half now. So it's kind of like, so I don't know what you would think about that.
Yeah, we won't speak directly to that without reviewing things and becoming your physician. So great one. I just see amazing how fast time flies, Marcia, when we're having a great time, but we have 10 minutes on the counter. So we'll try to be very brief to hit as many as we can. I do the side one, and then it looks like Jeb Smith family will be next for the chat room. So this one's from Jay Tandri, and this is for you. PKP2 positive family. He's the dad, he's the runner, long distance runner, never has had any symptoms. He's been hearing this thing about threshold exercise levels, and he's saying, honestly, this just creates more anxiety. What's this business about threshold exercise? And is it possible that he could stay a long distance runner? I'm assuming with kids, he's in his 30s, let's just say that, 30s or 40s, and still not ever show the disease? Or would you advise and say, I know it's never showed it, but instead of training for a marathon, let's just throttle back the running for a 5K kind of world? What say you, Hari?
It depends on the comfort level of what you want, right? What you want from life is what it is, right? So you really want to train, then you closely watch and see if what are you giving away for that, right? It's a give and take. And given the fact that it's a very slow developing condition, you're not going to make it worse overnight or even over a few months. So you'll have a lot of lead time. So if you keep doing what you're doing, keep your testing up to date and whatever, I think you could just, because it looks like at this point, you don't have the phenotype. You have the genotype of it, you don't have the phenotype. And clearly there are many things that decide the expression of the phenotype than just having the mutation itself. So I think you should be okay just doing it, but under close observation. We do recommend people take a beta blocker for whatever it's worth. Once you have the mutation, and if you're actually doing high levels of exercise, it just caps the amount of adrenaline that hits your heart and probably reduces your chance of having arrhythmias. But again, that's some people tolerate it, some don't. So it is sort of an individualized prescription. I think the cap rate of heart rate and everything else is a what's a Fitbit phenomena. It's just like people are monitoring their heart rate like crazy. So everyone calls me and asks me saying, is 130 okay? Is what I have a hard time hitting that right number. Either up or either down. How do you just keep it right there? So it is, you know, what it really tells you is it's like a moderate level of exertion. And of course, if you've been doing this for a long time, your heart rates probably stay low anyway, even when you're exercising. So I think it should be okay. I don't see a big problem with that.
And we'll give another myth buster tonight. This whole heart rate business, if you've been told to keep your heart rate under X, whatever X is, fake news. There is zero data that a heart rate that you keep under means you'll stay safe forever. I have never, as in never, given a heart rate ceiling for any of my athletes. And as you heard, 800 athletes, 600 without defibrillators, 0 rescue shocks, 20 years. So this, don't let your heart rate touch 135, otherwise you're in trouble. So that, hopefully knowing and hearing that, that might be a piece of good news, because I think we've created people to be Fitbit, Apple Watch freaked out by checking their pulse, thinking that, oh no, it's close to that number that the doctor told me, my heart's gonna blow. And that is all fake news. Marcia, I think
Jeb Smith family, go ahead.
Hi, thank you for doing this, you guys. Real quick, so I had a sudden cardiac arrest in October after playing tennis. I have an ICD. I was then told I could try to resume activity. I went to play tennis again and was shocked twice after playing. My question is, I never felt anything while I was participating in the sport. It wasn't until after I stopped. Is this normal? How do I know how to gauge what I can do? Side note, at the time of the second incident, I wasn't on any medication because they didn't know what the cause was. I'm now on metoprolol and the one that starts with an A. I can't pronounce it, or the one they give you in the hospital when you show up. So
amiodarone.
yes,
Yeah.
yes.
So I think what's critical for all sudden cardiac arrest survivors is to get a name for the disease and figure out, to their best of the ability, they are saying you did cardiac arrest because of a disease that I'm calling X, Y, or Z.
Oh yeah, so I have ARVC. C.
Yeah.
Okay, so one would want to look and say, what's the strength of evidence for that? Just as a frame of reference, the last time I put an ARVC young person with ARVC on amiodarone is never. So one needs to review everything to say how best to treat it. Do we know the genetic type of ARVC? Would we be using metoprolol? Is that, so once Hari and I were pleased with the treatment configuration, then we start to return that person to activities they love to do. And so it really is that approach where I'm not sure, I can't speak to yours as whether
Right.
I'm pleased or displeased with the treatment.
I get it. I guess my question is that when I'm exercising, I feel fine. It's not until after I stop. And is that normal?
That's perfectly normal. So what we do in the lab is we give a rush of adrenaline and then let it wash out. So what happens is that as the adrenaline level starts to come down, it's called the adrenaline washout.
Yeah.
Arrhythmias usually show up at that time.
Okay.
When you're in peak exercise, your heart rate is so high, so usually you can even suppress VT. VT could be happening underneath, but your sinus rhythm really can suppress it. It's called overdrive suppression. And basically when you wash out, that's when it happens. So it's typical, not only immediately after exercise, but if you actually did exercise in the morning, then later in the evening, your heart could be very irritable and jumpy.
Okay.
So it's common to have that. The second thing I would say is that if you know that you have an arrhythmia that can be triggered by exercise, putting you on an antiarrhythmic drug, meaning putting you on something, it's sort of like a Band-Aid, because it is sometimes it's going to break through. something, either physical stress or mental stress. And amiodarone, I would agree with Mike, it's not the right choice. The times that we have used amiodarone is a bridge to ablation. Somebody is really hot, a lot of arrhythmias and whatever, we suppress it with amiodarone just to do the ablation and then get them off the drug. So I think you have a lot to benefit from getting an ablation, more than anyone else. So.
Okay.
Interesting.
Or
Okay.
at least
Thank you.
somebody- Or at least somebody just like you.
Yeah, exactly.
Well, we are, Marcia, at the bottom of the hour, and I know it feels like we're just getting warmed up. And so maybe our webinar live group and those can reach out to Marcia, indicate a desire if you would want to do part 2 in the near future or next year. If this has been of benefit to you, we would love to do it again. We promised that we would respect time, and that's why we confined this to 1 hour for our evening here. And so this has been rich for me. I already have a couple of project ideas based upon your questions and your concerns to take to our research team to try to get smarter on your behalf. So I just want to thank you on behalf of the SADS Foundation and as president of its board. Thank you for your interest. Thank you for your partnership with us at the SADS Foundation. And thank you to you, Dr. Tandri, for giving up your 1 hour on the East Coast time as we hit 8:30 over there in our now Southeast in Nashville land.
Yes.
And so I'll let Marcia give the final wrap up, but to all of you, Happy New Year. I hope 2024 is a wonderful and hope-filled year. There's a lot of new advances happening and moving quite quickly in this space. New trials of new drugs, new trials of gene therapy for the first time ever. So we are getting better and better and better with SADS conditions, where the number of no's, you can't do this on the list, is getting really small. Here's the no's on my list for my patients. And if you can't see anything, that's because I almost have no no's for any of my patients. And I instead try to have my patients get to live large despite their SADS condition and to live and thrive, which is the motto of the SADS Foundation. So thanks for the evening. I've enjoyed it immensely. And Marcia, I turn it over to you for the final goodbyes.
Thank you very much, Mike and Hari. We really appreciate your time and expertise tonight. And I noted earlier that we do have frequently asked questions on our website, and one of the staff will put that link in the chat for everyone. I wanted to remind everyone that in 3 weeks, we are hosting another webinar on exercise and sports from the patient perspective on Tuesday, June 30th. We have members from 4 communities represented: ARVC, Brigada, CPVT, and Long QT. And we'll post the link where you can register for that particular webinar as well. So thank you everyone for joining us tonight, and have a pleasant evening.